Now, our next topic is embarking on the surrogacy journey. As many of you know, you sometimes come straight from the infertility clinic and you've just learnt the devastating news that you're unable to carry your own child. You'll have many, many questions. You really don't understand what the process is or where you need to go. So our next two speakers are going to give you a very insightful presentation. So our two speakers today are Dr. Hessler, who co-leads Oregon Reproductive Medicine's global practice and with his partners, and has helped patients from over 40 countries build their family. Dr. Hessler has an impressive CV in reproductive medicine. Our other speaker, Adrian Black, has been an active member of the ART technology field since 2003. Adrian has been a surrogate mum 4 times, so I'm hoping that she'll share some of those stories today, and has a strong belief in helping couples facilitate strong relationships between surrogates and IPs. Adrian is also the founding director of Heart to Hands Agency, who are one of our exhibitors here today. So please welcome our two speakers to take you on the journey of embarking on surrogacy.
Thank you very much. Sarah, how do I change the... Oh, is this the... Okay, great. It's truly a pleasure to be here in Sydney. I always enjoy coming back to Australia. It's a great opportunity for me to connect with former patients and see their children and to meet new friends. But first I'd like to introduce myself and tell you a little bit about my background. I've been the medical director of Oregon Reproductive Medicine for the past 20 years. I completed my education in biochemistry at Harvard before I went to medical school. And my medical training occurred at UCLA, where I completed a residency in obstetrics and gynecology. And then I moved from Los Angeles to Baltimore, where I worked at Johns Hopkins Hospital for several years. I completed my fellowship in reproductive endocrinology and infertility at Johns Hopkins. And then I remained on faculty as a professor for several years, where I was the director of the in vitro fertilization program. Our clinic, Oregon Reproductive Medicine, is located in Portland, a city of about 2 million people. For those of you who are not very familiar with U.S. geography, we're located between Seattle to the north and San Francisco to the south. So in a very beautiful and relatively rural part of the United States. We are one of the largest IVF programs, though, in the country, in that every year we complete about 1,700 IVF treatment cycles. And we have a team of about 140 staff. We're helping patients from around the world. And one of the reasons why patients come to our clinic is that we're able to offer specialized services such as egg donation and surrogacy. It's been a specialty of our program for many years now. Things to consider as you embark on your surrogacy journey. One is timing. As Sam has indicated, the whole process can take a while. Basically from the moment you feel like you're ready to proceed with the treatment till the baby is born can be 1.5 years, sometimes 2 years. So that's something to keep in mind as you're planning when you want to start your family. Another important question is, how will you find your surrogate? And today's and tomorrow's venue will be very useful for you to learn different options on how to find a surrogate, either here in Australia or in a foreign country. In the United States, the surrogate may not live necessarily near the fertility clinic where she's receiving treatment. So where your child is born will be where the surrogate lives, but that may not necessarily be exactly where the IVF process will take place. Budget's a very important factor for almost everyone, and the clinic and the surrogacy agency that you're working with, if you're working with an international program, will be able to give you a precise cost estimate of what the whole process can take. Many of the patients who come to our clinic are in need of an egg donor, so that's another consideration. Will you need an egg donor or will you need a sperm donor for you to complete your family? The basic steps in the IVF process include first performing medical screening on the egg provider and the sperm provider. And then when the treatment process begins, the woman undergoing the egg collection will take fertility drugs to stimulate the growth of her eggs. The embryos will be created. And in a fresh cycle, the embryos will be transferred into the woman's uterus, generally between 3 to 5 days after the egg collection. The process is somewhat different, though, for many IVF cycles, in that now, especially in the United States, most of the treatments that we're doing involve the use of frozen embryos. So with this process, what we'll do is initially create the embryos and potentially biopsy the embryos for genetic testing and freeze the embryos. And then at a somewhat later time, after the surrogate is ready, we'll thaw one embryo or possibly 2 embryos to place inside the surrogate's uterus. Another change that's occurred in North America, and I think in other regions of the world as well, is that it's become very common and standard to do some screening to screen for the potential of genetic diseases. So generally the woman providing eggs and the man providing sperm may have specialized tests of their blood to determine if they're carriers for any rare genetic diseases. That's done before the treatment commences. And now, again, it's quite common to biopsy embryos. In our program, about 80% of patients that we're helping elect to have their embryos biopsied to determine if the embryos have normal chromosomes or abnormal chromosomes. Historically, the woman in the United States or in Australia who's had the egg collection has been the woman who's carried the pregnancy. But of course, in the case of surrogacy arrangements, there's a third person involved in the process. So that does add, to some extent, some degree of complexity and requires more planning. Quite often, the woman providing the eggs and the surrogate are not going through treatments at the same time. Their treatments might be separated by a year or even several years. But if we think about the basics of IVF, the first step involved for the woman who's undergoing the treatment process is to take fertility drugs to make her eggs grow. And when a woman is on her menstrual period every month, generally more than one egg will start to grow inside the ovaries. The eggs grow inside small cysts called follicles. But we might have as many as 20 or 30 follicles that begin to grow, but normally only one of these would grow to a large size and release a mature egg. However, in an IVF cycle, women typically take injections of follicle-stimulating hormone, and that causes more than one egg to grow, and it allows us to collect more than one mature egg. The eggs that we're collecting are eggs that were predestined to grow that month, so we're not using up the woman's eggs. We're able to collect them and use them for fertility purposes. This is an ultrasound view of a woman who's undergoing ovarian stimulation for IVF. And you can see each black circle there is a growing follicle. The black that we can see on ultrasound is the liquid inside the cyst. So it's quite common, particularly for young egg donors, to make as many as 15 follicles in each ovary. 15 eggs may grow in each ovary. The egg collection is done under IV anesthesia, so patients generally don't feel the process, and it typically takes about 25 minutes. We use a vaginal ultrasound to visualize the ovaries, and then a needle is passed alongside the ultrasound probe. The needle will enter the ovary, and we're able to collect the fluid. So the liquid comes into a collection tube, and then the embryologist will take the tube and examine the liquid under a microscope to find the egg. So typically the embryologist works in a controlled environment in a clean room laboratory to ensure that the egg is not exposed to any dust particles or chemicals that might lead to problems with the embryo quality. Once the egg is collected, it's inseminated with sperm. We can either use fresh sperm or frozen sperm for the process. Either the sperm is placed in the dish with the egg to allow the sperm to naturally penetrate the egg, or we'll inject a single sperm cell into the egg to fertilize the egg. And then we'll allow the embryos to grow in the incubator in the laboratory. So the embryologists will view the embryos at different stages of growth, and they're able to assess the development of the embryos based on the rate of development of the cells, the rate of cleavage of the cells, and the appearance of the cells. So you can see in this image here, the 3-day-old embryo has approximately 8 cells inside, which would be a normal cell stage for day 3. When the embryo reaches an advanced stage, it has more than 80 cells inside, and it forms a type of embryo called a blastocyst. So you can see on the right the blastocyst. And the group of cells on the left side of the embryo are the cells that will grow into the baby. They're called the inner cell mass. Generally, about 50% of the eggs that fertilize may grow into an advanced embryo. So it's quite common for some eggs to stop developing, or some embryos to stop developing during the process. One of the advances over the past decade in IVF has been in the realm of genetic screening of embryos. It's possible for us to remove a small number of cells from the embryo when the embryo is 5 or 6 days old, so that we can analyze the chromosomes. And primarily what we're looking at is the number of chromosomes in the cell. What we find is that there are relatively high rates of genetically abnormal embryos during early embryo development. So with this additional tool of genetic screening of embryos, we can identify the embryos that can lead to normal children. So typically the embryo is biopsied and frozen, and then the genetics lab will analyze the cells that have been removed and issue a report to indicate if the embryo has 46 chromosomes, the correct number, or if it has a different number, which may lead to an embryo that would not implant, or would lead to, potentially to an abnormal pregnancy, one that would miscarry or lead to a child with disabilities. Then when the surrogate is ready, we will treat the surrogate with hormonal medications to prepare her uterus for the embryo transfer. Usually embryo transfers do not occur in a natural cycle. We treat the woman with estrogen and progesterone medicines to prepare the uterus, and in doing so the woman will not ovulate that cycle, so that we know that when she does conceive with the embryo that we're placing in the uterus, the embryo is coming from our laboratory and not one that was created by her having intercourse with her partner. So typically the surrogate will initially take estrogen for about 2 to 3 weeks to cause her endometrium to develop, and then she'll begin taking progesterone, and the embryo transfer will occur on the 5th or the 6th day of progesterone administration. The embryo transfer is actually a very simple but important process. We place a speculum in the woman's vagina, and then we insert a small catheter through the cervix into the uterus, and we'll deposit typically 1 or 2 embryos in the mid aspect of the uterine cavity. So the catheter that we use is very soft. The woman will not feel the embryo transfer. And then we hope that after we place the embryo inside, that it will continue to grow and attach to the uterine wall and lead to a pregnancy. And we're able to do a pregnancy test about 9 to 11 days after the embryo transfer to know if the woman is conceived. This is just general information giving you an example of a typical outcome if we're treating a woman in her 20s. This could be, for example, an egg donor, in terms of what we would expect to achieve. There may be approximately 25 or 26 follicles that grow on ultrasound, and then when we go to collect the eggs, we'll usually get an egg out of almost every follicle that we aspirate. But out of that group of initial eggs that we collect, there may be some that are immature and will not fertilize. And then When we do place the sperm in with the eggs, we expect that the average fertilization rate in a young group of eggs would be approximately 70 to 75%. So we might have 15 eggs that fertilize. Out of that group of eggs that fertilize, roughly half will grow into an advanced embryo by day 5 or day 6. And then if we do genetic testing on that embryo, what we may find is that approximately 65 to 68% of the embryos will be chromosomally normal. So by starting with initially 25 eggs, we might have about 5 usable embryos. So this would be a very common outcome. And then when we place the embryo in the uterus, one would expect that the implantation rate would be 50% or higher. So it is important to have more than one embryo in order for the parents to achieve their goal of having at least one healthy child. The embryos are selected for placement in the uterus based on a variety of criteria. Of course, it's very important that the embryo has an excellent appearance microscopically, so the embryologist will grade the embryo. In the US, it's become very common for embryos to be biopsied for genetic screening, but it's not a requirement. We certainly do treat patients where we don't biopsy their embryos. And in some circumstances, we'll test the embryos for genetic diseases if we know that the parents are at risk of having a child with a disease like cystic fibrosis or muscular dystrophy. This is data from 2 large genetics laboratories who reported the rate of chromosomally normal embryos based on the age of the egg provider. So you can see in this table that even when we're working with eggs from a young donor, there's a significant percentage of embryos that are genetically abnormal. But the rate of abnormalities really does increase with age. So genetic screening is probably most useful and most effective if the woman undergoing the egg collection is over age 37, because as a woman gets older, the rates of genetically abnormal embryos increases. And we certainly want to select embryos for placement in the surrogate that have the best chance of leading to a normal pregnancy. This is data from our program where we looked at implantation rates using genetically screened embryos versus non-screened embryos over the past 7 years. And what we found was that in all age categories, we did have higher implantation rates with the biopsied embryos. So again, this has become quite common at our clinic. It is possible, as Sam said, to look at statistics of IVF programs in the United States through 2 websites, the CDC website, which is our government's website, and also through our professional society's website, the Society for Assisted Reproductive Technology. And now it's possible to actually identify surrogacy pregnancy rates and live birth rates through the SART website. So a lot of Americans rely on this data when they're planning their journey to get information about the potential success rate based on their background and based on the clinic that they're working with. So in conclusion, you're here today to learn more about surrogacy, and you are in the process of writing the story of your family by participating in this conference and by making plans for the future. So I certainly would encourage you to consider the relationship that you may want with your surrogate. It can vary depending upon what country you're working with. And keep in mind the time frame, as Sam indicated, it takes a long time to have a baby through this process. So that can be important in terms of your budgeting of time and financial resources. And assemble the team that can help you achieve your dreams. Thank you.
Hello, everybody. It's really a genuine pleasure to be here and to have an opportunity to talk about my true passion, which is creating families through surrogacy. My name is Adrienne Black, and I am the founder and director of Heart to Hand Surrogacy, and I'm also an experienced surrogate myself. I have carried 4 times for 3 families. The first family was a U.S. family, and I carried singletons and then twins for that family. I carried twins for a family in Istanbul after that, and then most recently I carried a singleton for a set of gay dads in San Francisco. So feel free to come by and ask me questions. I'm pretty open about my journeys. A brief introduction about Heart to Hands. I opened my agency in 2011, and our agency is built on the idea of providing heart-based, ethical, and exceptional care to surrogates and intended parents. We have 5 employees. 4 of us are pictured here. We have all been surrogates multiple times, and then our operations manager in the back, Jim, who probably would have been a surrogate if he had had a uterus. And between all of us, we have a combined experience level of about 30 years. And so we've seen a lot of the good and a lot of the bad, but more good than bad for sure. And we serve approximately 30 to 40 families a year. About half of those are international families like yourselves, and the other half are U.S. families. So I have a brief amount of time to give you a lot of information about the surrogacy process, so I'm going to fly through it. But what I really want for you to take out of this is that this is a very individualized journey. Everybody's story is going to be different. Every child's creation story is going to be different. And so even though I'm going to give you a general timeline and a general process, it could look a little bit differently for you. So a quick look, it does take about 18 to 24 months to do a full surrogacy journey. It could be a little bit more or a little bit less, but I would say that you probably want to plan for about 2 years. Today we're going to talk very quickly about choosing your providers, the matching process, the screenings, legal agreements, the cycle transfer and testing process, pregnancy, parentage, and then birth. The first step is choosing your providers, and arguably I think this is one of the most, if not the very most important part of the process. Usually you're going to start with choosing your clinic. When you're thinking about choosing a clinic, make sure that you interview several. Things that you want to consider as you're interviewing is the proximity to you, the clinic's success rates, the services that they offer and the programs that they offer, and then also the clinic's cost. Make sure that when you interview your clinic, you have an opportunity to discuss your specific needs with the clinic. And then the next step is going to be to set up your appointments for a fuller medical conversation about your needs. The next step is usually that you're going to choose your agency. And when you're choosing your agency, it's a similar process. First, you're going to consider whether you're working with just a surrogacy agency or a surrogacy and donor agency. Many clinics offer in-house donor programs, which is a lovely way to go. But if you're looking for a very specialized egg donor, you may choose to go through an agency that is separate from the clinic. It really depends on what's available and what your needs are. Just like your clinic, make sure that you are interviewing your agencies thoroughly. You want to ask a lot of questions. You want to talk to them about what your needs are. And then you also want to ask specifically, how long have they been in business? How do they do their screening? Who do they refer to? What kind of funds management practices do they have, and what kind of funds holding services do they use? And then the cost of the agencies. The next step after you have interviewed agencies and have decided that you like a specific one is that you're going to fill out all of their paperwork, because there's always a ton of paperwork involved with this process. And then they're going to do background checks on you. And the background checks are just basically to make sure that you don't have any kind of significant history that would be damaging to a child. Now, I am very US-centric because that's where I practice, so there may be some variation in how this happens depending on the country that you choose to go through. The next step is choosing a donor and matching with a surrogate. The donor process, you want to make sure that you are looking at several profiles, consulting with your physician to get an idea of what donor is going to be best for you. When you're choosing a donor, the things that you want to consider are the specific traits that you're looking for from a donor, her availability, because she might have blackout dates when she's not available to cycle for you, how close she is to your clinic, whether she's a repeat donor and what her success rates were, how her previous cycles went, if she is a known donor or an unknown donor, and we're seeing that known donors are really the preference more and more, and then of course the cost of the process with the donor. When you are matching with a surrogate, it's a similar thing. You want to have the option to look at several surrogate profiles. You might choose the first one you look at, but you should have the option, if you would like, to look at more than one. You want to make sure that you meet the surrogate. This could be in a video chat, or it could be in person. It depends on what your needs are. You want to make sure you discuss your expectations around the very important topics such as termination, selective reduction, those sorts of things. And then once you have found somebody that you think is a really great match and you've met each other and discussed those things, then you're a match. Step 3 is the screenings. Your surrogate and donor will both go through medical and psychological evaluations. The medical is an in-person medical evaluation that includes a physical of the surrogate and donor, case history, blood work, drug tests, and a uterine evaluation and ultrasound. The psychological evaluations include meeting with a licensed mental health care provider who is familiar with surrogacy. They do an in-person interview. The husband or partner is also usually involved in this process. And then a mental health test is given to make sure that she is mentally prepared and doesn't have any concerns or issues that would say she is not prepared for surrogacy. Step 4 is the legal agreement. You'll be referred to an attorney, and your surrogate will be referred to an attorney to help go through the entire contract negotiation and preparation process. There can be some back and forth. This is a little bit of a challenging process sometimes just because you're talking about things that are hard to think about. Step 5 is cycle transfer and test. Now, if you have frozen embryos already, which is what's most common now, then what we're really focusing on is the surrogate. But if you have not yet frozen embryos, then that would be the time that the donor or intended mother is also going through the egg retrieval, IVF, and PGS or genetic testing process. With the surrogate, she'll begin medications. They'll do the embryo transfer. Then is the dreaded 2-week wait where everybody stands around and waits for about 10 days till we can do a blood test that indicates whether the surrogate's hormone levels are rising. 2 days later, there is a second blood test. We'd like to see the numbers rising again. Sometimes there's a third blood test. Sometimes we just move to the heartbeat ultrasound at about 7 weeks. If you are one of those that is lucky enough to have a successful first transfer, then we move on to the regular typical pregnancy. And that would be at about 12 weeks, the surrogate moves to her own obstetrical care provider. This is treated like a typical pregnancy with no difference in care. We'll go through all of the first, second, and third trimester, and then the birth occurs. And of course, the hope and expectation is that you are there for the birth and that you are the first person to greet your baby after the doctor. Step 7 is parentage, and this varies according to where you are, where your surrogate is, and even what country you're in. In the U.S., it's most common that parentage is established prior to birth, typically between 18 and 28 weeks of pregnancy, so that when the baby is born, you are the actual and legal parent immediately. Thank you. Step 8 is birth. Really, the goal is that you be there for this very, very special moment. This is the creation story of your child, and this is the moment that surrogates really live for. They really want to see those first few moments where you're greeting your child. At a certain point, suddenly you know that it's time. If you've gone through this over and over and you've been through a lot of loss, or maybe you're just starting your journey, at a certain point, it's just time. You have to just take that leap. You have to trust in the process and the people that you have chosen to provide care to you, and you just have to say, I'm ready. So again, the thing that I really want you to walk away from is that this isn't just a linear process. This isn't just A to Z in a process like I've outlined. This is about a relationship. This is about a creation story, and this is about family. So as you go through this, the next 2 days, and your head fills up with more and more and more information, just take a deep breath once in a while, step back, and kind of find that place of heart, because that's what surrogacy really is. Thank you.
Thank you, Adrian and John. Now, we've just got a couple of minutes if anyone would like to ask some questions. Now, Karen actually has a microphone, so do we have any questions from the audience? Karen, down here at the front. Karen's just going to bring up a microphone.
Thanks, Dr. John and Adrian. Adrian, I have a question for you. When you mentioned about you are going to refer a maternity to a surrogate and a parent, is it actually the same maternity, like the same lawyer? Oh, sorry, the same lawyer.
In the U.S., the surrogate always has her own attorney, and the intended parents always have their own attorney. And the intended parent's attorney is generally who originates the legal agreement, and the surrogate's attorney reviews it with her, and then there's some back and forth until they come to agreement. The attorneys are almost always located in the state of delivery, which is where the surrogate lives.
Thanks, Adrian. Is there any more questions? I did see another hand up.
Sorry, this is just a sideline one. Are some of the slides available for access at some point in time?
I can make them available.
Lovely, thank you.
If you just want to go out to the desk during one of the breaks and just ask about that. Any more questions? No? Okay. Well, we'd certainly like to... Oh, yes, one more. The microphone.
Hi. I just wanted to find out, Dr. Hessler, if you do any of the programs that are offered. I think I had seen once in New York from a clinic there where they do it with 2 eggs from the actual intended parent and the egg donor. Do you do programs like that?
So are you talking about trying to place mitochondrial DNA? Actually, the FDA is not allowing that, so it's not supposed to be clinically offered in the U.S. at this time. So it's considered experimental in the U.S. So no, we're not offering that.
Thank you, Dr. Hessler. Now, just mindful of time, so it was a very insightful presentation from Dr. Hessler and Adrian. And as I mentioned before, if you do have any questions, please go and talk to them out in the exhibitors lounge. But I'd just like to take this opportunity to thank you both for participating, and your presentations were extremely interesting. Thank you.